Sir, we are good to go, sir.
Yeah, recording is start.
It will be still in the YouTube, sir. No recording recorded.
Okay, fine. Yeah, very good evening to one and all. I welcome everyone for this panel discussion on an interesting or an important topic on a practical approach to dissertation. Dissertation, which is very important for a postgraduate and also a practicing surgeon. I welcome everyone and I request our chairman, Dr. H.V. Shivaram, sir, to give the welcome address.
Thank you, Dr. Chandrashekar. Good evening, everybody. It's a wonderful meeting we are having today in the new year. The first meeting is for our budding surgeons, that is the postgraduates. A lot of them have newly joined first year and they are wondering what to take for thesis. And this is a new thing for them. They were not taught in the MBBS or so. So every teacher is also guiding. So we thought it's best to have an eminent faculty to deal with this topic. I must thank Dr. Shrishail Metgud, who has gathered an eminent national faculty, Dr. Pawanindra Lal, Dr. Lakshman, Dr. Nanda Kumar. All of them are experts in their own field. So without much ado, I hand over the Zoom meeting to Dr. Shrishail Metgud to introduce the speakers and also conduct this webinar. Thank you, everybody.
Good evening, everybody. At the outset, I would like to thank our chairperson, Dr. Shivaram, and Chandru sir, whom we affectionately call Chandru sir, our secretary, for giving me this opportunity. And also Kalavani madam and Hepsur sir for giving me the guidance that was required for this webinar. So we'll start. Just have one or two words to add before we start with the webinar. Way back in 91 to 94, when I did my post-graduation, we had no idea of doing a dissertation, and we all did it for compulsion's sake because it was required by the university. But now things have changed. We need to know about research, we need to know about publication and all that. And that is the reason why this was thought of. And continuing its tradition of keeping the PGs informed about the various aspects, clinical aspects, etc. So many aspects. KSCASI also thought about this particular topic. So without wasting much time, we shall proceed with the webinar. The first speaker for today's webinar is Dr. Professor Pawanindra Lal, and well-known laparoscopic and gastrointestinal surgeon. He also is a well-known oncology and a bariatric surgeon. Sir's CV runs into pages, so I will not go into the all the details, but just I would like to highlight few of them. Presently, sir is the director, professor, and head of Department of Surgery, Chairman Division of Minimal Access Surgery at Maulana Azad Medical College, and also is associated with the Lok Nayak Hospital, Delhi. Sir has won the numerous awards in the last so many years. Notable amongst them is he is an award recipient of BC Roy National Award 2016, Commonwealth Fellowship Award in 2007, International Guest Scholar in ACS in 2012, and he has more than 100 publications, and he has more than 300 paper presentations. And it is also important to note that Sir has contributed 2 chapters in the Bailey and Love Short Practice of Surgery, which we consider as a Bible of general surgery in the 20th edition as well as in the latest edition. And Sir also is associated with organic farming, home composting, and is a sports and fitness enthusiast. So I'm sure Sir will enlighten us about writing a protocol for the PG thesis. Over to you, sir.
Thank you very much, Dr. Metgud and Dr. Shivaram, Dr. Chandrashekar, and all the leadership of the Karnataka State Chapter of ASI. Warm greetings and a very good evening to all the faculty members, colleagues, and students. I'm really pleased to be here as part of this webinar series. I would just start by the topic which is given for my thing is to how to choose a topic for a PG thesis and how to write a protocol. I bring greetings from my institution, and in the next few slides we'll talk about why it is important to write a protocol and why is it that it is very important, what are the steps before writing it, what are the various components, and is protocol really the mirror of your thesis research. Protocol as a dictionary meaning refers to a system of rules that explain the correct conduct and procedures to be followed in formal situations. In our own parlance in medical sciences, it is a plan for a scientific experiment or for a medical treatment. And in another way, it refers to a document that describes the details of a treaty or formal agreement between countries. So obviously we are, in our own parlance, we are talking about a plan which we want to write for the conduct of a scientific study that we wish to do during our postgraduate thesis year. So I'm sorry for this mark, but I think it will stay there. So protocol, I would really say, is equal to a thesis proposal. It introduces the research topic. It outlines the relevant recent literature as is applicable to the topic, and it specifies the problem and the objectives that you wish to do. It describes the methodology to achieve those objectives and also the statistical methods that are proposed to be done during that study. And the aim of the protocol, therefore, is to convince the department or the institution committee that the research is worth undertaking and serves as a guide to elaborate the thesis upon. So, you know, it is really the mirror of whatever you wish to do. And once you write a protocol, you are completely bound by it to conduct the thesis as per the protocol definitions. Now, what is the component? I'm not sure how the line has come in, but yeah, okay, it's fine now. So what are the components of a protocol? Well, it has got the introduction where you give the background knowledge about the topic. You give the lacuna in the current knowledge, which is actually filling up the reason why you wish to do the study. And then you fill it up with an aim. And the aim, very importantly, has got two important parameters, the primary endpoint and the secondary endpoint. To achieve those, you describe the patients and you describe the methods, which describes the methodology and the patients that you are using, how you are doing your study material. You describe the statistical analysis that you are going to use for the conduct of that particular methodology. You have to describe your follow-up and you have to give your annexures. What are the main components of a protocol? Well, the main component really is the topic, which is really the null hypothesis. And I'll just come to it in a moment. The topic helps you to choose. Topic is very important. So topic helps you to choose the guide, as well as vice versa. Sometimes the guide helps you to choose the topic. So both ways it works, and I'll dwell on it when we talk about choosing the topic. It's also very important to see who is your supervisor or the guide, because the kind of research study that you are going to conduct, especially in the Department of Surgery, is going to be largely determined by the kind of surgical work that your supervisor or guide is, doing in that particular unit, and there are, good number of reasons to be doing that topic with the supervision of their supervisor or guide. So when we talk of choosing a topic, now this is a broad definition. To choose a topic that you are interested in, the research process should be more relevant if you care about your topic. And if you narrow your topic to something manageable so that you don't make it very broad. If you make it very broad, you have too much information and you cannot kind of focus. You need background reading that can help you to choose and limit the scope of your topic. You need to review the guidelines on topic selection pertinent to your particular topic. And obviously, you discuss with your guide for further suggestions. So let's talk of choosing a topic. If we talk about the topic itself, if it is well known, if it is well established, and if it is already scientifically proven, then there is really no point in selecting a topic like this. So basically, you are not doing anything new, and you are just repeating what is very well established. Now, I use these three things. Well known may not have been studied. Still, there may be a reason to do it. There may not have been any level 1, level 2 evidence. Well established, there could have been studies which are comparative studies, but they are not reached the level of randomized controlled trials. There could still be a reason to do it. And then these are scientifically proven and well established, and there is no real point. So if you were to choose a topic like to compare the benefit of laparoscopic with open cholecystectomy for gallstone disease in the year 2024, majority of the teachers here would agree that this is absolutely not relevant as of now, because it is well known, it is well established, and it is scientifically proven. So what do? How do you go ahead if you can't do a topic like this? Well, you need to choose a topic which is relevant to your practice, relatively current or recent. There are adequate number of cases that you can have for that particular sample size. If you choose a topic which is very rare or not done in enough numbers in your hospital or in your unit, then you will not be able to get adequate cases to complete the sample size. You also need the expertise to conduct the study in the department or unit faculty. So if you do or choose a topic which is related to a particular type of surgery, and that surgical procedure is not done in your unit, you will not be able to get a sample size. And you should also have a meaningful follow-up, because thesis has a time limitation. And also, I would like to say that many a times the topic actually turns out to be a topic for a problem for your supervisor rather than for you. You must understand that the topic is your research and not of your guide or supervisor. Ultimately, you need to be making sense about the research that is going to come out as a result of your thesis work. This is a topic that I have given as a sample. ETEP Reeve Stopa, that is enhanced view totally extraperitoneal repair, Reeve Stopa repair for ventral hernia, or one of the modern abdominal wall reconstruction techniques. Now, this particular operation, if you were to study in your unit as a part of your thesis topic, would need expertise, it would need operation time, and it would need a follow-up which has bare minimum 3 months. Although any hernia recurrence is not studied for less than 6 months, 1 year or 2 years, but the bare minimum that you would need is 3 months. Now, if the last date of thesis submission, for example, for the current batch which is completing their thesis, is 28th February, My question to you is, when would the last case be operated? So I'm repeating this again, and it is just an exercise for all of you. If the last date of thesis submission is 28th of February 2024, when would you be when would you need to do your data analysis? At least 15th February for the latest, because you need to complete your at least your statistical analysis, and that statistical analysis would lead you to writing your discussion, and this leaves only 13 days to write your discussion and make a conclusion and summary and answer the primary endpoints and secondary endpoints that you raised to begin with. Very tight. I would say very, very tight. Even with this very, very late data analysis date, when would you need to complete your last operated case? With a 3-month follow-up, that would need to be 15th of November. So you can imagine that for a thesis to be submitted by 28th of February 2024, you would need to finish your data enrollment case by 1st of November, which is the right time, or maybe 15th of November, which is cutting very tight. So you have to work backwards to calculate the time that is sometimes required to finish your thesis. The recent thesis topics of other institutions can be used as a guide, but they should not be copied. Recent research in conferences and meetings gives you an idea of the topics of current research, especially those that are discussed in panel discussions. And there could be a good reason to use lingering controversies. For example, abdominal sheath closure, various methods, suture materials, emergency, elective, and then timing of surgery, for example, in acute cholecystitis, which is still an emerging topic of research and could be a relevant topic if you have enough cases related to this particular disease. Then you come to your aims and objectives. And when you write your aim, it is the intention of what you have to achieve. Objectives are the steps taken to achieve the aims. Aims are broad, objectives are specific, and we use what is known as the SMART, which is specific, measurable, achievable, realistic, and time constrained. They refer also to the primary and secondary endpoints of the study. So what is the primary objective or endpoint of a clinical study? Is the endpoint for which the study is powered to achieve. So that is the main primary objective of your study. The secondary objective or endpoints are additional endpoints, which are preferably also pre-specified, but for which the study or trial may not be powered. So when you went to say the power of the study, that means the statistical answer with the number of patients that you have taken in your sample size is basically designed towards the primary objective or endpoint of the study. So power of a study represents the probability of finding a difference that exists in a population and adequate number of patients in the study based upon available published research, which make your sample size. Methods should describe your study design, whether it is prospective, randomized, study period. Materials, those are the patients, therefore inclusion and exclusion criteria. The sample size, the methods with brief outline, pre-operative workup, operation details if relevant, because this is only a protocol, post-operative follow-up, duration of follow-up, which is 3 or 6 months, depending on the study, as I just told you. And then you will come to statistical analysis, which is being discussed later on as well by experts, which is generally a comparison of one new or novel surgical technique versus the standard. And therefore, there are two groups. There could be a qualitative data, there could be quantitative data, and therefore you have to decide which type of statistical test to use for for calculating the significance of difference. And if there is a correlation, then you have to use the appropriate formula and also mention the software that you need to use. And then references are usually single page, less than 10 in number, with detailed consent in local dialect and in the English language. The patient performa for each case has to be shown, and there has to be a sample master chart which needs to be prepared. And my penultimate slide is this. This is the thesis topic that I had given to my postgraduate in the year 1999, when total extraperitoneal hernia repair had just started. 97, George Ferzli from America published the study about the experience of his 6 years in TEP. And just 2 years after that, we conducted the first randomized controlled study comparing TEP with inguinal, with open hernia, the Lichtenstein repair. At that time, we had only 25 patients compared between the one arm and the other arm. But this, because of its good study, because of its relevance, because of the quality of the study, became one of the most cited studies. It entered the textbooks like, textbooks like Sabiston, even books written by stalwarts, Bittner, and this, is there for you to see that thesis topic of a postgraduate can actually become one of the most successful, papers in its own way. And the thesis student, who is the second author, Ramkrishan Kajla, is now a faculty and a professor and a head of a unit in one of the medical colleges in India. So that's how the importance of a thesis is. Thesis can make your careers. It can take you places. If it is well done, it's not the numbers that are important. It is the way that it is conducted that it is important. So to summarize, protocol is the mirror of your thesis. It is the framework on which the thesis is performed and written. Whole thesis would heavily depend on your topic and protocol, and therefore all inherent steps mentioned in it are very important. A badly framed protocol would lead to a badly done research and a badly written thesis, and therefore it becomes very important. So I would like to thank all of you for your patient hearing, and I would like to also invite you to this meeting that we are conducting at Maulana Azad Medical College in February next month on obviously on minimal access and laparoscopic surgery. And you can see there are many topics. The reason I put it here is there are very many topics that are here for the postgraduates to see. You're talking about topics for surgeons about handling difficult coli, learning ETEP or transverse abdominis release, doing comparison between TEP and enhanced TEP, doing comparison between IPOM and ETEP reef stopa repair, and various other things. So I invite you, and thank you very much once again for this opportunity to present this work today.
Thank you, sir. If there are any questions, chat box.
Chat box, no questions.
No, there are no questions in the chat box.
Can I ask one question?
Sure,
Yes,
sir.
please, sir. Please.
Professor Lal, wonderful talk, and very nicely guided. I just want to know, in your department, you must be having a protocol, how when a new PG batch joins, how do you tell them, or how they choose the topic for the thesis, or you have a initial discussion with them, then different meetings, and finally how the topic is chosen?
So thank you, Dr. Shivaram, for this question. Well, I would say that there is an institutional training process of 2 days in which all the postgraduates of one batch of all subjects together are given a brief outline about the way they are going to do this protocol work and their thesis topics as a general kind of a class. And they are also given a basic idea about the statistics which they need to do, which they need to know. And so that is a general thing that is done at the level of the college. At the level of the department, once when the students are distributed to their supervisors by the department chairman, then we discuss the topics which are currently under research, because sometimes the currently research topics are the way to do further research. They're on a ongoing research. So sometimes we use the ongoing research. We also encourage the students to do some more research on their own to ensure that they bring out the topics of their own interest. But as I said, topics of their own interest are not just important. It's also important that the adequate number of cases are enrolled. For example, they bring sometimes topics on acute pancreatitis. Very good, very nice. But how many pancreatitis have landed into the unit in the last 12 months is what they need to see. If only 10 cases were treated by that unit, then what research will they be able to do? Because that's the approximate number that is going to come. So the sample size of the cases that they want to do is most critical. Also, the surgical expertise of the guides and the supervisors that they are doing. Suppose they want to do, as I had told in this particular presentation, something in AWR, and they are not having that expertise to do the AWR, then that topic will become very difficult to accomplish. And sometimes teachers, in the enthusiasm to do newer research work, take topics which are very which they are new to them, and therefore in their own learning curve, the data for the student thesis work becomes highly skewed. That's also a challenge, because they take 2, 3, 4 hours to do a case, which when they are fluent might take just 30 minutes or 1 hour. So there are many things that are, there are confounding factors to many things when you choose a topic. But obviously the research work that is going on in the unit, the surgical scope of the teacher, the kind of patient load that is available in the unit, these I think are the important determinants which ultimately decide the topic that a PG student gets to do.
Thank you. Thank you very much.
Sir, I have a small query, sir. Rather, I want your comment on this, sir. Many times, because of more number of postgraduates and deficiency of some topics, we encourage the postgraduates to take topics from other specialties like pediatric surgery, urology. Your comments on that, sir? Is it the way to go ahead, or should that be discouraged, sir? Because they won't be spending.
No, I think they should be encouraged to take the topic in the surgical department only, because that is like passing the buck, and that's not a good strategy at all. So if the teacher is getting a particular student for a PG research topic, then it is as important for the teacher to ensure that there are, and for the department and the unit to ensure that there are adequate number of cases to be done by them. Otherwise, it defeats the purpose, really.
Thank you, sir. It was a very nice, informative talk, sir. I'm sure it will benefit all our young trainee surgeons. So, thank you, sir. Now we move on to the next topic, that is literature search and collecting data by Dr. K Lakshman. I'm sure all the students in Karnataka know about Dr. K Lakshman. Sir is a consultant surgeon in Bangalore. He's the former associate editor of Indian Journal of Surgery, and he has set up the DNB program in Sagar Hospital, set up the digital library and skill center at BMC. He's also the life trustee of BMC Development Trust. Also, one thing I would like to add is, during the COVID time, along with the KSCASI, sir ensured that the teaching program for the postgraduates was not interrupted, even because of the COVID restrictions. and it was really helpful to all the postgraduates. I welcome you, sir, and request you to continue with the second topic of today's webinar.
Thank you. I hope my slides are seen and I'm heard.
Yes.
Yeah, thank you. Dr. Metgud, thank you for your kind words. I would like to thank KSCASI for giving me this opportunity. When Professor Pawanindra Lal has made such a lucid presentation as an introduction to the topic, life becomes easy for me. My job is to try and explain what we do in a literature search and how we collect the data. But before I get into that directly, I would like to say that generally postgraduates have little enthusiasm in doing research work, but times have changed, as Professor Pawanindra Lal said, and it's very, very important for a postgraduate to focus on learning surgery as much as learning some basics of research and evidence-based practice. The word cutting I have used deliberately within inverted commas here, because I think that is something that should be banned from our the language of our postgraduates. Everybody wants to know, do I get enough cutting chances? Cutting is a bad word. I think at least give it the decency of saying operating chances. But please understand, you will learn to operate. Always you will get the technical skills. It's a matter of time. But what is really required is that you become a good scientific and evidence-based surgeon. And for that to do that, for you to achieve that, you must straight away focus on thesis work, which is an introduction. And as Professor Metgud said in his very introductory talk, you should not do it because you have to do it, because somebody is forcing you to do it. You have to do it because you want to do it. It's a very simple formula. If you show the enthusiasm, you'll find that everything becomes quite easy. But when we talk like this, particularly to the first years, everything looks very complicated and daunting. All I have to say is, do not be overwhelmed by all this information. A 20-minute talk, like I or Professor Lal or Dr. Nanda Kumar is going to give for each of us, we have 20 minutes. It's not, we can't, explain and make you understand everything. Our job here is to reassure you that it is not a big, it's not a big topic to be scared about. And second, we would like to introduce you to the terms that are generally used. You get familiar with it, but if you keep practicing about listening to such lectures, attending such webinars, listening to this very recorded version again if required, and if you keep practicing some of the things that I'm going to tell you on the computer, things become easy. And as Professor Lal very lucidly showed, the thesis topic became a very popular paper. I was very pleased to see that paper. I read it quite some time ago, and it is a truth that if you look at your thesis as a research project where you aim to publish a paper, you will be able to do good work and get a paper out of it. Several of our DNB students who have done thesis work have managed to publish papers as well, and that is a fact. And so please do not take this aspect of your surgical training lightly. The other thing is that you must have some degree of computer savviness, as they call it. Most of our students they know what to do, but something focused for research has to be learned. Everything is available on the net. Nothing that any of us is going to say and it's available free, is something which is exclusive. You can have access to digital libraries, but please note that whatever is available on the net is not something that is to be believed blindly. Go for peer-reviewed sites. Again, you must understand the meaning of the term peer review. It is where people of similar specialties get together and they have approved a particular document or a paper to be of some substance. Because anybody can put their personal views and they may not necessarily be generally accepted. So peer-reviewed sites, peer-reviewed articles have to be depended upon and not anything that is on the net. And this is also, understand the word index journals. I'll tell you what the indexes are in the next slide. But Professor Lal, when he said that you need to know what is already known about the subject before you embark on something to fill the lacuna in that subject. So to know what is already known about your topic, you need to have a review of literature. And the review must come essentially from peer-reviewed articles that exist or that are listed on indexed journals. The old time, when I was a student, there were no computers, and we were depending on a volume in several volumes of printed index called the Index Medicus. The electronic version where searching has become very easy is now called the PubMed. But that's not the only index. There are several recognized indexes. This is the SCI from Thomson Reuters, the Scopus, the MBBS, and the DOAJ, the Directory of Open Access Journals. It's good for you to try and reach each one of these, but your workhorse, the main index that you refer to, would be the PubMed. Now, what happens in the PubMed is that if you want to put a search topic, you literally get hundreds and thousands of articles. It's impossible for you to focus on what you want to do. And so to help you narrow the search and focus on this topic of your interest, the topic of your thesis or your research, you need to use what are called Boolean operators. These you can learn only with practice. You've got to keep trying it out on the PubMed or any other database that you might approach to get your information. But remember that these are words or symbols words in capitals or symbols that you use between search terms. In the next few slides, I'll show you how it makes a difference. And means both terms, the one before and one after the search term that you put will be shown. All the articles will be shown. If you say either or, it could be either of them. If you want to exclude something, you will have to put the word not. And if you want a group of words to be considered together, you got to put them in brackets like this. So if you want the terms to be next to each other in your title or the text, then you've got to put inverted commas on it. Now, if I say it like this, it's not something that you'll quickly remember and understand. So I'll show you how a simple topic can be approached as far as literature search is concerned. Suppose your interest is in laparoscopic surgery in gastric cancer. Let us take it as an example. If you just put gastric cancer on it, look at the number of papers that you have, 133,000 articles. All right. So it's very difficult to go through this and get the relevant information. Also note that the PubMed gives you mostly abstracts. You don't get full text, you get some full text, but most of them are abstracts only. And another site, which I'm going to show you, called the PubMed Central, will give you full text articles. Suppose you put this term, you see, I have defined gastric cancer in inverted commas. What I'm telling the computer, in whatever articles that you search, gastric and cancer must be next to each other. That's what the inverted comma means. And then you put the term and so I'm limiting it to surgery. The next word that follows is surgery. I'm limiting it to surgery. So it won't tell you, it won't show up articles about chemotherapy or radiotherapy or whatever else, immunotherapy for gastric cancer. So you can see from 133,000 articles, it's now down to 29,000 articles. All right. But remember, it gives you all surgery. So you want to reduce it to laparoscopic surgery. That's the point of interest. So you put gastric cancer, the words which have to be together, and that is the other Boolean operator here. This inverted commas is a Boolean operator. And I also specified now that you must have laparoscopic surgery, the two words sitting next to each other in the search term. So if you put that, then you will find that it is down to about 800 articles, a lot more manageable than otherwise. All right. There are other ways in which you can search the PubMed. You can see that there is what is called the mesh term. If you see, this is the main window. If you see the PubMed search, this is the main window. To the left, you have this drop-down list, and you can use what is called the mesh method of searching. Mesh stands for medical subject headings. These are preset headings in the database. And so instead of putting those words yourself, you can select the ones that come in the database. I have changed the topic as intra-abdominal hypertension here. So when you put the mesh headings, there are so many headings that are under intra-abdominal hypertension. But suppose your interest is only in diagnosis and complication. You just have to tick those two. When you do that, it will put the complex search term in the box that you would have otherwise written. It is so if you look at what is shown here, abdomen and inverted commas and all sorts of square brackets and all of it something you can type in by hand if you know what it is, if you're good at it. But if you don't want to do that yourself, the mesh head settings, the medical subject headings, a mesh system can allow you to do the same thing, and you'll further narrow down your search and get similar articles. There's also a concept called fuzzy logic. Fuzzy logic is really not enough, but if you want to get a quick thing without having to get into any of these Boolean operators or any of the mesh headings, computers and databases understand common English sentences. So all you have to do is papers on laparoscopic surgery in gastric cancer. If you put that, and you can see the computer has given 79 articles. It may give you a window into what you want to see, but for your thesis, the fuzzy logic search would not be enough. All right. And as I said, this is from a PubMed. So you get only the abstracts, the titles, and other, author details and the things like that. But if you want full text, you need to go into the PMC, PubMed Central. What is on top is the URL for PubMed Central. So if you get into the PubMed Central, and it also understands the search terms and the Boolean operators, if you put those in that, then every single article that it throws up would be a full text article. And that is quite useful. Sometimes that may not be adequate because you may not have full text for everything else. So you can get the article details from your PubMed, not PubMed Central. Go to your digital library. Most institutions have digital libraries. From there, you will be able to get the full text articles. And one little trick I would recommend, if you do not get your full text article anywhere, most of these things will give you the email of the authors. So if you write to the authors, most authors will be very happy to send you a full text articles of their own work, because every author's intention is that his work is read and cited by people. So you can write to the authors through an email, and they will help you by sending you a full text article. You can also have many filters. This advanced button there will tell you that it gives you many types of filters. One of the examples I have shown here is the duration. You may not want to find articles which are more than 5 years old or 1 year old or 2 years old. So you can specify that there are several such filters. Full text articles are all full text articles, but review articles can be one of them. You want it to be less than 5 years old. Sometimes it throws up animal studies. You want only human studies. So all of these things are given in a filter, and you can select the ones that you want through the filter as well. Professor Lal has given you the overview of the protocol. This slide and the next slide are as a recap for you. And there are only two things I would like to highlight, which he has already mentioned. Please note that one of the things for you to learn is to know how to do a research study, the thesis. In that, sample size calculation, methods of randomization, ways in which blinding is to be done, all these are to be learned. And it is understood that with so many postgraduates, you can't have the kind of sample size that the calculation tells you to have. If the difference between two groups is very small, the sample size calculation will tell you that in each group, you must have 500 patients. In 2 years that you do, you won't have it. You may have 50 patients. But I'm sure the authorities, in fact, we saw this and we were discussing with the authorities, particularly during the COVID time, the numbers were extremely small. So nobody rejected a thesis on the basis of a small size. You can quite honestly and rightly say that this is the sample size that I expected, but within the time limitation that I have, I could get only 15%, 20% of that size, and I have done the analysis. What is important is for you to learn how to do sample size calculation, how to randomize, how to do blinding, and learn the statistics that my subsequent speaker is, the methods of analysis that he's going to speak about. The methodology has to be learned. nobody really holds you responsible for smaller numbers, particularly knowing the current situation in the patient load and the number of postgraduates we have. The other thing you need to have, again, out of the scope of this particular presentation, because it's a whole topic by itself. Professor Lal mentioned this as well in writing the protocol. You must learn what are the kinds of studies. Is it prospective? Is it retrospective? Is it descriptive? Is it interventional? Is it randomized, non-randomized? Things like this. In a retrospective study, what are the things that you have? But in any study, any design, this is where we find a lot of deficiencies in the studies that we see. People must know what the confounding factors are. I'll just say one word about it, but when you write your protocol, you must focus on it. For example, you're looking at the healing rates of a diabetic foot. All right. So you're comparing saline dressings versus, let us say, insulin installation on the wound. Okay. There are several factors which impact on the healing. And so if you want to say that the good results that you got from, say, insulin installation on the wound versus just saline dressings, you have to make sure that all other factors which influence wound healing are accounted for, but it's not, other factors are not working on this wound. These are the confounding factors. So which means that you have to make sure that the two groups you're comparing have similar vascularity, that there is no vascular problem associated with it. There are no bacterial factors associated with, there are no nutritional factors different in these two groups. There are so many others, if I go on, I can list about 8 or 10 factors which are confounding factors for a wound healing. So what I would like you to think about is understand the word confounding factors and make sure that when you compare two groups, you make sure that the two groups have differences only in the intervention, only in the thing that you are changing between the two groups, and all other factors remain the same. In terms of collection of data, analysis will come later. I just want to tell you that you can either use any form or any sheet. It can be, I use Google Forms, it's freely available, it's on the net, and it's easily distributed or shared among people. You can as well use an Excel sheet and a form that goes with it. But what is important is that today, to have a master sheet like we had, which was, we used to stick several pages together and have a huge, broad, wide thing to get all the parameters. Today, it's become very easy with the advent of sheets. These are called spreadsheets. I'm going to talk about Google Sheets because that's the one I most commonly use. The beautiful thing about Google Forms is data entry in Google Sheets is difficult. So you can as well design a Google form, and the Google form automatically dumps the data into sheets. So when you collect data, you use a Google form, and when you have to analyze, you go to the Google Sheet. It's as simple as that. We did a study on the surgeon's lifestyle, and as you can see, we sent it to all the surgeons and of members of ASI, for example. And this is how you have several data points. These are all individual data points. And we've used what's called a Likert scale, where they can choose what their answer is. And so for them, it's very easy to enter. And this is automatically converted into a spreadsheet. And when you come to the data analysis, you come to the spreadsheet. I know that you can't understand and execute it tomorrow. But what I would like you to do is understand the word spreadsheet, go and play with Google Forms and Google Sheets on the computer, and you will quickly get a hang of it. The other thing I would like to stress is the importance of informed consent. This country, unfortunately, is notorious, has a bad reputation that we do research without properly informing our subjects, without properly informing our patients. I think it's a very sad commentary. Things have tightened up in the recent past, and I'm glad that things are improving. But even at this stage, apart from getting a very good protocol and a good thesis topic and things like that, please focus on getting a completely informed consent from the patient, particularly if there are any costs involved. And please focus and tell them that there is no obligation for them to say yes. We had a very simple study which was comparing central fixation versus lateral fixation for IPOMs. And somehow, even though we explained very nicely that there is really no difference in terms of recurrence and pain and all that. We are just studying it. Just that fact was that many people told us we don't want it. So we were actually it was very difficult for us to get the numbers that we needed, but we never changed our protocol of getting an informed consent. And those who refused to participate did not participate. And also tell them that they can opt out if it's a study which has several steps and you need to see them 3-4 times. If they want to opt out any time, they have a right to do so. And the only other thing that is important, apart from getting your protocol and your data management systems going, is to make sure that you have permissions from everybody. Permissions from the scientific committee, the ethical committee, permission from the institution and the HOD, and you may get data from other units. It may not only from your units. So you got to go and get permissions from the heads of other units. I have already mentioned about the informed consent, but also with a view to publishing a paper, it's always a good idea to consider registration with CTRI, which is this Clinical Trials Registry of India. There are many registries, many recognized registries. Some journals, in fact, insists that before accepting your paper, that your project or research must be registered with a recognized registry. So please give a thought to registering your study with Clinical Trials Registry of India. And this is their URL. I would strongly recommend that you go and visit them. And what is very interesting is that they have an e-tutorial. You can actually take the tutorial. It is designed by, hardcore scientists and, statisticians. And so surgeons like us may find it a little heavy, but don't get put off by that. Do the tutorial and you'll learn a lot of things from the tutorial that is available on CTRI. I mentioned about the master sheet. We had a hard copy those days, and today it is a spreadsheet. Usually you must go for all these things: demographic details, investigation, and interventional details. We have mentioned about the outcomes. Collate data. You may have groups and subgroups, and you may want to do that as well. And data analysis is something going to be spoken about by my successor in this webinar. Please make sure that there is some kind of interim analysis. It is important that you are meeting the targets, you're not only in numbers, but also in the way in which you are collecting data. It is important for you to know that, all the data points are properly filled. And at the end of 2 years, if you find that something is not complete, then this thesis will be a big problem. At the end of the study, you have to do the analysis and get your discussion. And, as Professor Lal said, write the thesis, give yourself adequate time. Always aim to present your data at a conference and write a publication. I finish by saying that all this may look very daunting, particularly when you're starting out as a first year, but it does become easy as time goes by. But enthusiasm, diligence, and honesty are very, very important in your work. A dishonest research work or thesis is much worse than no thesis. So please understand, complete honesty is what has to be used in any kind of scientific or research study. Thank you very much for your patient listening.
Thank you, sir. As usual, it was very informative. There are no questions in the chat box. I have one question, sir.
Yeah. Questions are there.
Yeah, they're there, sir. Yeah.
Yeah. Is there any way of searching for topic looking into the common cases seen in a given institute? Yes, sir. The unit head can specify what the common cases are. So once you know the topic, you can use these tricks that I mentioned to get all the latest information about it. The second question, is there a minimum number of cases? I don't think so. Perhaps Professor Lal can answer this better. I have always approached any thesis as an exercise in the learning of the research methodology. Now, one of the big problems, if you insist on a minimum number of cases, people will cook up numbers. And that's a very, very sad thing. So as a professor or as a unit head or whatever, I would just want them, even if they do 25 cases, I'm happy. 20 cases, I'm happy, as long as they're honest and that their methods are sound. Because once they start practice, once they have learned this process, over a period of 4 or 5 years, they may get 200 to 300 cases. Whereas in the practically, their time for collecting data is 18 months, sir, not even 2 years, I think. Maximum 2 years. In that time, to expect them to have 150, 200, 250 cases, honestly, I think is unreasonable. So I would appeal to everybody, all the powers that be, to not insist on numbers. They must know how to calculate the sample size. They must know that for their study to be valuable, it must have 150 cases, for example. But if they have 50 cases, I'm happy with it. They can quote it as a limitation in their thesis or even in a paper. Paper may not be accepted because they may not accept, but in the thesis, I'm sure the authorities will accept if the methodology is sound.
Sir,
my question was about artificial intelligence.
Very, very good question. It is an evolving field. I have kept in touch with it almost on a daily basis in this. As of now, I would not allow anybody to use AI in any of the work that they do. There are many limitations. There is what is called an AI hallucination. If you put a question to a chat GPT, for example, it will not say, I don't know. It will actually cook up numbers, it will cook up information, and then give you something which is wrong. In science, it is extremely bad. Second, one of copyright. When you do your references, you have to attribute something that is already known, some information that you've got from a source. You have to attribute it. It's called annotation and citation. You got to say, this is the guy who did that study. Now, none of the AI information that you get attributes it. In fact, ChatGPT has been just sued by New York Times for millions of dollars for using information from the paper and not attributing it to the paper. So please understand, AI is just not correct in this. But as an experiment, I might add that I experimented with AI for a paper. I had written a paper, the whole text, the data, everything was written by me. I put that whole information into ChatGPT and asked it to give me an abstract. All right, we write abstracts at the end of having doing all the papers. It will probably take me about 1 hour to do an abstract of a paper because I have to give a structured abstract, get everything, all that, think about it, revise it and all that. ChatGPT gave me an abstract from the information I gave it within 7 minutes. And it was as good as the abstract I would have written if I had, if I had written using my own brains and all the information that I had. This doesn't mean to say that you must use AI for your abstracts. I was just giving you an example that in this situation, it could not give me wrong information because what I fed it was entirely my true information and true data. So in one word to answer you, Dr. Shivaram, no AI in research as of now.
That's the message. I think every student should get it. Don't try and use AI to do your thesis or research project.
Sir, I would like your comments on plagiarism, sir. I'm sure it goes on in some places, some way or the other. So I would like you to your comments on plagiarism, sir.
Yeah, I ended my talk, as you noticed, with honesty. Honesty is everything. Honesty in numbers, honesty in collecting data, honesty in attributing the information you have to somebody else, and never ever copy a thesis. We find that people take shortcuts. They copy, huge segments of people, other people's thesis and put it in their thesis. Please understand, it beats the very purpose of training you as a surgeon. We need to have ethical, efficient, and knowledgeable surgeons at the end of your MS or DNB. If you have dishonest people, particularly in surgery, it's a life and death matter. I'm helpless in asking people to be honest. I know that some people under my nose are dishonest, but the appeal is always there for all of us to be completely honest all the time. Many times I have actually in the past in my own unit, I knew that a person had said that he had 35 cases and he had only 18 cases. So I forced that student to take away the other 17 cases. I forced him at that time. I said, don't increase numbers. He was getting desperate that he was not getting the numbers that he needed. But I said, numbers are not important. That's one of the reasons I said honesty, not only in collecting numbers, collecting data, and all the writing must be in your own words. And you can quote somebody. You can put it within inverted commas in your article, say this is a quotation from this particular paper, and give it as a reference. That is perfectly allowed. For example, a definition of chronic inguinal pain after hernia repair. It's an obvious definition. So it will probably be given in another paper or a textbook or whatever. Then you put that as a definition and say, this is where I got this information from. That kind of honesty is important. Also note that universities and many publishers are using automatic anti-plagiarism software. They have checks, and if they find that the number of passages which are similar or copied from other places exceeds 25 to 30%, then you can get a notice about it. So please note that plagiarism software is available, and so you're not being honest because somebody is checking you. Okay, as a professional, you're honest for the sake of being honest.
Our eminent Dr. past presidents are joined, Dr. Siddesh, Dr. Sanjay Jain, and others. I welcome all of them for this webinar. Dr. Shailesh, you can continue.
Yeah. Thank you, sir. I now will be introducing our next speaker, that is Dr. Nanda Kumar BS. He is Professor of Community Medicine in MS Ramaiah Medical College, Bangalore. He also has a postgraduate diploma in Health and Hospital Management, a DNB in Community Medicine, and his core areas of expertise include primary health care, telemedicine, public health informatics, health technology development, population data management. And he has extensive professional experience as a technical analyst in medical evidence, and he currently holds the position as Associate Dean, Research and Innovations. He also heads the Research and Intellectual Property Rights, and as I said earlier, he is the professor in the Department of Community Medicine at MS Ramaiah Medical College. I request sir to tell us how to compile the results. Over to you, sir.
Thank you, sir. Thank you for that. At the outset, I thank the organizers, Dr. Kalaivani, and the senior leadership at Association of Surgeons of India, Karnataka State Chapter. Apologies for the voice, had a bad throat. And however, I would like to continue from where Dr. Lakshman sir has left, for the reason that artificial intelligence, being the Associate Dean at Ramaiah, one of our thrust areas is to research on artificial intelligence. In that context, I fully agree with sir that when we are using the AI, we have to know what knife or what tools you use. And in the hands of a surgeon, a scalpel becomes the best tool. Similarly, when you look at AI for research, ChatGPT is like a general butcher's knife. You won't be able to use it with precision. But today, there are curated, what you call as research supportive AI systems, which actually, as sir told, it would be in 7 seconds, the abstract would be written, not even 7 minutes. Because they are large language models, which put together and synthesize. It is a machine which is working to do a task more efficiently. That's it. But the efficiency is self-learning, and it's able to provide some additional things which sometimes will add to it. Probably on a different occasion, we can look at use of AI for research in surgical sciences. Probably I would request Shivaram sir to organize that as a symposium, wherein you can bring in multiple people from the industry, because today 80% of research in AI is happening in the health domain. EduTech and health tech are the two largest users of AI and ML. And in the probably next 2 or 3 years, we'll be having a lot of supportive and assistive systems in healthcare. So that apart. The second thing is about the plagiarism. As sir told, almost all universities today, be it Rajiv Gandhi University or our own Ramaya University, we ask the student to attach a anti-plagiarism or a report, which will say that it shouldn't be more than 12%, not even 20%, 12%, for the simple reason that we want the students to at least cite from where they have taken it. So in that sense, ethical research is far more important than no research. The third component is about the sample sizes and availability of material, especially with what Dr. Kalaivani told. It will be almost like an undergraduate batch, 25 or 30 students in each year of post-graduation, into 90 or 100 students. Where will you find research topics? So in that context, one of the things that you can look at is pooling of samples and giving multifaceted components to a particular topic, which will be taken by 3 or 4 students, maybe in a unit or together, so that the sum of such topics will add up to the statistical significance and help them to publish a more multidisciplinary or a multifaceted research on a particular topic. Today, we see that the research is being on the 3 RRR component: repetitive, regressive, and redundant. The reason for it is we are going with a very rigid framework. The 4th R is the rigid. So as some of the teachers say that we need to be a little bit flexible in our approach. Open-mindedness needs to come in so that the students are guided and supported to explore adoption of that interdisciplinary or a multidisciplinary approach for ensuring that the research is not just doing something for the purpose of doing, but also will add some evidence to the practice. As Dr. Lal showed, dissertations can certainly be published, and that should be the aim of any research. So if you have publication at the end of your mind, all these principles, the right design, the right analysis, the right power of the study would be brought into it, so that you will be able to provide a more feasible and what you call as generic research, which would help in advancing the sciences. So in that context, I'll just move on for the specific topic, because I was given to understand that the methodology and others would be covered, and it is the analysis and the results part of it. But for this purpose, the 10 minutes, it's impossible, as Lakshman sir told, even to talk about the scientific statistical analysis, because that is a separate topic by itself. So I will just restrict myself to the results part of it and touch a little bit about the biases. The most important difference that a student, or sometimes even as guides, we get confused between the two is, what is the difference between that of a dissertation and that of a publication? Because as and when, as teachers, when we sort of like mature in our professions, we would be looking the research in the form of a publication. We would be seeing how we can put a p-value to it, how we can put an inferential statistics, which is sometimes daunting, how we can sort of like place the result to the world in a positive manner. In terms of dissertation, it is very clear that what we are trying to do is how the work was done, what is the observation from that work, and what is the inference, and that inference in the light of current evidence or body of knowledge, what it means to practice, what it means to science. This is what the results part or the findings of the dissertation that we are looking at. So when we look at the steps, it is moving from general to specific, because in a dissertation or a thesis, we often look at only a small component. It is not that finding a solution or something which is totally outside the box. Many a times it is meant to introduce the research methodology to the student so that they can learn the art and science of doing research. So we need to understand that there are several criteria, and one of the good resource that students and even as teachers we can learn is this wonderful publication by the British Medical Journal, one of the associate editors, Trisha Greenhalgh, where she speaks about various components of interpreting and writing papers. So for dissertation as well, when you read this thing, how to read a paper, there are several components in which tells how to write the result section, how to write the inferences, and how to summarize your results, and how to draw conclusions from that summary. So just adding to what the previous speakers have spoken, especially with regards to the topic and the methodology, unless we have this finer criteria applied, it becomes very, very routine. As Lakshman sir mentioned, many a times, not just copy paste, it is actually repeating the topic after 5 years and seeing that like what has been done, and to say that in our setting, or using a slightly different technique for the same topic. So what happens is the novelty part of it, the interesting part of it, especially to the community of surgeons, will be so low that whenever they present it in a conference or try to publish it, the response will be very, very minimal. So in that context, as Sir told, you can actually look at a literature review and extend it for a Google Trends, wherein you will be seeing that in your topic or in your area of specialization, like gastro or any other type of surgery, what is trending. So in that trending topic, even if you take a smaller number of cases, you will be able to make a case series or a slightly smaller comparison of an observational study, which will have some weightage and not just look at an analytical study or an interventional study with inadequate power. So please ensure that the I and N part of it, because ethical and relevance is a given. You can't do research without those two things. But when you look at the interesting and novel, we are not talking about the interest to the student, but interest to your community and your experts. So when you look at the results section as such, I'm just skipping the part of analysis, because by and large, most of the times the analysis is supported. I'm using the word support, not outrightly contracted to a statistician. Usually what happens is you have to tell what you need, and we find that gap when we get the data from the students. They say that, sir, give me a p-value. Very often, even the statistician who is absolutely not an expert in your domain would say that give me a reference article or the article from where you started, and they will try to match or map the analysis to that, and you will find that neither your results are in line with that, both from the actual results and the statistics part of it. So in that context, the idea is to understand what you want, especially from your objectives, and when you revisit your research questions, what is it with which you have started? Are you looking at whether the new procedure or the new approach is better than the conventional approach? If so, how are you measuring that better, quote unquote? So there should be an objective outcome which is measurable, which is repeatable, and which is valid. I'll talk about it a little bit later. But you need to revisit your research questions both during the study and once you have got the results. And you need to have an idea about how you are going to present your results, so that the logic of reading it for someone who is uninitiated, suppose I, as a community medicine person, would want to read and see that whether it is relevant to a population or to a larger community, you need to be very clear in describing the demographics of the population to which the results are applicable. The third is the demographic data, because as Sir told, there are huge biases. Probably in one of the slides, I'll just touch upon it. And unless we know who are the people who are involved, who are recruited, who are the subjects of that particular study, and where it was done, it would be very difficult both for internal validity and external validity. The third is composite measures and the data shaping, where we say that unless I mean, you can have the height, you can have the weight, but unless you have a BMI, it doesn't make sense for interpreting something. So the length of stay, average length of stay, hospital infections, unless you know who are the patients, was it an ICU setting, was it a ward setting, or was it just an OPD where the patient came in for a dressing and the wound healing took certain time. So unless you know the setting, the type of patients and the interventions, it would be very difficult for you to write the results, more so to infer it and discuss it. So there are two broad statistics. I will not get into the depth of it. The first is the descriptive statistics, where you're describing your population, describing the comparison group, who are the people who were intervened upon, who had the surgery using laparoscopy, who are the people who had conventional surgery, and what is the difference between the two. That is the descriptive statistics. Then you have the inferential statistics, which says that what differences that you are seeing in the two groups, is it by chance or is there a true difference beyond the chance? That is where your confidence intervals, type 1 and type 2 error, the power that we speak of, all these statistical mumbo jumbo come in there, so that the person who is interpreting or the person who is reading your dissertation fully knows that the results that you are claiming to be from your study are not by chance alone. And another simple thing is, many a times we see that students saying that, sir, I need 5 graphs, 2 bar graphs, 3 pie charts. Charts are a very, very powerful means of presenting your results. So try to use them in the right manner, for the reason that if you are using a bar chart to depict a continuous variable, probably it will not be yielding the kind of impact that you need to give. Similarly, when you're using a pie chart where it has around 20 categories, the slices will be so thin, you won't be able to make a difference. So look at what right type of graphs and charts or the pictorial descriptions can be used and try to use them. The next is the important findings of the results need to be highlighted. So coming to this topic of the internal and external validity, I'll spend a minute on this, for the reason that unless you know that the results are relevant to your own study, you won't be able to say that this technique is sort of like very apt to be used generally for all types of indications. So you need to understand that, are these conclusions believable within the framework of the study, which talks about the internal validity? How does this research apply to your practice? When you say your practice, general surgery in general. So that is the external validity. These two things depend upon various components of your methodology, the design that you have adopted, the setting in which the actual study that has been done. There is a huge difference between an urban and a rural setting, because the techniques, the tools, the interventions, and most importantly, the skill of the surgeons can differ, and they can contribute to the difference in the outcomes that you would have seen. So based on adjusting for these potential confounders or biases, the selection bias, the interpretation bias, the reporting bias, and the actual collection of data, you will be seeing that unless you adjust for these various biases, the results will always have an element of difference, which you won't be able to explain. So what is the difference between an inference and an observation? Because you're in the result section, and most often, including the teacher, sometimes we get confused. We look at something and say that this is the inference, but it is only an observation. What is seen or what you observe as an outcome is only an observation. Once you add science to it, logic to it, compare it with similar studies and draw some conclusion, that is an inference. So in most of the dissertations, in many universities, they have the result section separate, discussion section separate. In Rajiv Gandhi, many a times they have results and discussions. So where we have the first 2 lines, we say there were 34 males and 12 females in the study. That is your results. But when you're inferring, you need to say that since the condition is more common among males, the proportion of males included in the study reflects the trend, and hence in this study, the results that are being seen aligns with the current body of knowledge. So that gives a weight to what you are trying to interpret, and the reader is very clear that the why part of the results, that is, if you are getting a result similar to something which has been published, still you need to explain. If your results is different from what already is being published, then still you need to explain that probably the setting was different, or your approach towards that particular thing was different, or the outcome measurement tools were different. So these are the things which needs to be kept in mind while you are presenting your results, and unless we are very clear and concise, we will be confusing. So just to reiterate, precision refers to the clarity with which, I'm not talking about the statistical precision, which is measured in numbers and confidence intervals, but precision of the results in terms of the actual results without extrapolating, without going beyond the scope of your objectives, and without trying to be extremely, what you call as different from that of what is being stated in your research question. So in that context, ensuring that the study that is undertaken, however small it is done very diligently, following the axioms of a research question, a hypothesis, objectives, study setting, study population where you include the people of interest, and among those whom you have included, you should have an exclusion criteria. If you are doing a study to look at the outcome among 30 to 50-year-old male patients, then the exclusion criteria which we often see is all females are excluded. Unless you have included them in your study, you don't exclude them. It is like in a hotel menu, only there are 12 items, and you cannot say, I don't want this because there is no such item. So please be sure about the inclusion, exclusion criteria, statistical methods, sampling, the way in which you write the results with a description of the population, demographics of the population, and summing up the inferential statistics, which gives you the differences in actual numbers using a correlation coefficient, chi-square test, pair t-test, or ANOVA, or any other regression methods, and trying to discuss those results as a very clear why it is agreeing with the current body and why it is different. So I will stop here and take a couple of questions if there are any.
Thank you, sir. In spite of having just recovering from cold, you made us aware of the correlating all the data. Thank you, sir. If there are any questions. So there is one question from Dr. Gurushantappa, that is analysis and finding p-value should be done by the candidate with the help of social medicine faculty rather than giving to a non-doctoral statistician person.
Yes, sir. But most of the times there will be one statistician or none in medical colleges. So usually it is outsourced. That is why I told that it is contracted. So, but however, what I would suggest is today there are tools and there are means by which, if not the actual analysis, at least the interpretation should be done with the support of someone who knows. And community medicine to a large extent will be understanding what it means, and we need to use the right people. And I have found many a times even surgeons or doctors, we can understand, we can interpret. So it should be done in the light of the subject-specific statistics rather than statistics-specific subject. That's what I feel.
Dr. Nanda Kumar,
Sir,
what stage the statistician should be involved in the thesis process? From the beginning, or at the middle stage, or at the end stage?
sir, it is before the beginning, I would say, for the reason that unless we know it is feasible, because it all depends on what is the objective of the dissertation. If it is to publish or present, or if it is an intervention or an RCT, if there are no sufficient number of such cases, then there is no point in even starting the study. So as you are rightly saying, it should be even before, when you are having 2-3 topics, meet them and find out whether the numbers that is required is feasible. If it is feasible, involve them from the beginning to ensure what is the sampling method, what should be the randomization and other things.
Right.
May I, sir?
Yes, madam.
Yes, madam.
I think, Dr. Nanda Kumar, we always look at, when we go for a study, whether the sample will be adequate or not, we look at the statistics of the hospital.
Yeah.
The number of patients, total number of patients, and among those patients, how many such cases, the study of interest, say for example, inguinal hernia with a laparoscopic approach, how many cases are there coming to that hospital with that disease? Based on that also it is being calculated, right?
Yes and no. For the reason that...
Please explain, yes.
For the reason that a thesis, as Lakshman sir told, is an introduction to the research. Okay. So the research has to be done within the institution. So towards that, we retrospectively see the feasibility of such cases being operated, have a buffer of around 10% or 20% on either side, and say that you take this much as the sample. But if you actually look at it, that is where I was trying to say at the beginning, why we should restrict a student to do only in Saptagiri, only in Ramaya, or only in some place. Why can't the Association of Surgeons say that, look, this year, these are the thematic areas of interest to the ASI. So we are going to support 10 such topics, which will have a sample size of 500. With the luminaries like you, it is not at all a difficult thing. 500, just imagine 5 students doing, collecting data, having a monthly review, having a 6-monthly symposia, how much body of knowledge that you can provide to both Karnataka state, India, and probably the world. Because the number of surgeries that happen in academic institutions, when you put it together, will be humongous. So when you're calculating the size, don't try to restrict it only at the institutional level. We do that as a matter of convenient sampling. So the idea is to apply the statistics so that at the end of it, it should be valid. Otherwise, it would be just another, what you call as activity under the broad research framework.
It's a good idea what you're giving. Yes, higher ups should be taking it up. Really, that it really makes a lot of sense.
Yeah, thematic areas, sir, just I would say that thematic areas of interest, because I was called in Endocrine Society and other places, and when we explored it, they realized that there are 10 or 15 areas which are emerging for which there is no Indian evidence. So probably you can, as a consortium, pull up and get those topics and support it with a very minimal, because today financial support is not the only thing. If you say that the permissions and the colleges will be more than happy to ensure that there is a separate seed funding for that, and you will be able to really make an India-specific guidelines for a large number of surgical interventions. Please.
Yeah, sir, I think a time will come when we'll have to collaborate and cooperate with other institutes. As you rightly said, we are running short of research topics with the increasing number of postgraduates. Probably a day will come when we will have to do this. Thank you, sir.
Dr. Hebsur, after that, Dr. Gurshantappa.
Sir, Dr. Nanda Kumar, sir, it was a very good talk, and we really enlightening talk. But I just want to ask you whether mentioning it in the particular institution or particular area, is it required? Because in every institution, there may be patients coming from different places. And the area may be different also. Like in KIMS Hubli, if I mention, I may get a patient from Bengal. I may get a patient from Haryana. I may get a patient from local also.
Absolutely, sir. Got the question. This refers to the study setting and study population. The setting is KIMS Hubli. The study population is diverse. So your external validity, unless there are sufficient representation from Bengal, sufficient representation from the areas or the catchment areas, it will be wrong. But to answer your question, the study was conducted in a tertiary care hospital can still be mentioned, but not a study in South Bangalore, laparoscopic outcomes in South Bangalore. So because there is a huge difference between the setting and the population, which you have clearly told, you have the answer. So I'm just reiterating it.
Okay, sir. Thank you, sir.
Some questions are there, Doctor, in the chat box.
Yeah.
Sir
Yes,
Nanda Kumar, sir.
Yeah, please go on, sir.
Yeah, if I have understood correctly your versions, like getting the patients for the study from different institutes. And if I understood correctly, am I right?
Yes, sir.
Yes. For the postgraduates who have been allotted seats through some the process and through some universities and being allotted to particular institutes, in the dissertation we'll be mentioning that yes, this is the duration of the study and this is the place of the study.
Yes, sir.
So it will be a particular institute where that institute the study being conducted in that particular period.
Yes,
so
sir.
according to you, to have more number of cases for that particular topic, to include another 2-3 institutes, which may be attached to that particular university or which may not be attached to that particular university. So is it applicable or feasible?
Sir, I'll give you the solution. We need to write to the Rajiv Gandhi. Some of them are office bearers here. And as Lakshman sir told, it is more of a mindset. While we are saying that if the study is ethical today, for breast cancer cases, we have sent our students to Kidwai. We have sent our students to Nimans, and we have told that it is in conjunction with that. So what I'm saying is, operational feasibility is something which is we need to be taken care of, because we might not be able to send every postgraduate, given the tight schedules and duties that you have, to multiple institutions. I'm saying if you take a topic which is relevant, there might be 20 cases, 15 cases on an average at different places, and without worrying about the number needed to get that statistical significance, on a whole, you will still be able to have a very good evidence from those multiple centers. It will be more like a multicentric study. Just to give an analogy, it would be a multicentric study which protocol is same, but the centers are different. Ethical clearance, I'm also adding that, needs to be taken at each center. So the guide will be from each center. But the topic of interest, the protocol of interest, and everything will be standardized so that you can say that it is the KSC study which has been done in 2024 with 10 different centers. And for these 10 different topics, you will be having a sample size of 400 surgeries, which is impossible in a dissertation.
Yes, sir. I think if I am permitted, what Dr. Nanda Kumar is telling is already acknowledged by NMC now.
Yes.
Probably if teachers like me are apprehensive about what the university tells or what the NMC is going to tell, it is categorically encouraging us to go for different collaborations and area of interest in the surrounding institutes, especially, or even the remote institutes where good quality of work is happening.
Why not private, madam? You can go for private also.
Yes,
provided,
sir, definitely.
Provided the ethics and the protocol, patient confidentiality is maintained, which I'm sure most of the good institutes have that, with DNB programs happening there.
Yes, sir. Yes, sir, definitely. And it definitely adds significant value. And ultimately, if we are genuinely interested in converting our quality data into publication, this definitely matters. Thank you. Thank you for wonderful suggestions.
Dr. Kalaivani, anything, anybody else?
Some questions were there, sir, in the chat box.
Yeah.
What questions? I think most of them are answered. Anything left out?
There's one more question is there regarding validation, external validity. Your explanation is a bit confusing.
Lakshman, sir. It's for
Lakshman, sir, your
Lakshman,
comments
sir, your
on it.
comments.
Yeah, I mean, I would like to reserve my comments on it, but yes, I think Nanda Kumar gave a different version of the validity and external or internal. The way we understand it, Dr. Nanda Kumar, is that if you have a questionnaire, for example, about a particular topic, we then look at the validity at both internal and external of that particular questionnaire, and get a few experts in the field for this kind of validity and calculate through statistics the kappa value to know whether that particular questionnaire is a valid questionnaire or not.
Got it.
That is the kind of restricted view we understand as internal and external validity.
Got it.
Yours was an expanded version of it, if I'm not mistaken.
No, sir, you're absolutely right. Validity of the questionnaire, again, has internal and there are four this thing: construct validity, criteria validity, face validity, and coherence. So which is by kappa is one way to look at inter-observer thing. That will say whether the instrument used to collect the data is valid. What I was referring to was the study results, whether they are valid. Using that right instrument, it is very valid. What findings that have been done. Whether it is applicable across the country, across the world, is external validity, which we use in terms of any research. If you say that within it is like ideal testing conditions, you are getting that result with this protocol, which is very valid. But when you go on road, when you go in a traffic area, whether will you get the same mileage, that is external validity. Hope I have made my point clear.
Yes, I think can we stop at this stage and continue our discussion? Dr. Shailesh?
Yes, sir.
Shrishail,
Shrishail. One thing I would like to inform everybody is I think we had a record number of PGs attending, sir, this webinar. Almost more than 100 students had attended, and I hope they have they make good use of this, the knowledge that they have gained from this webinar in doing their dissertation. And also, somebody just messaged me on my mobile. A few students from neighboring state, Maharashtra, also had joined us, sir. I think they got the link through their friends in Karnataka and they had joined. I think they.
Sir, may I add one thing?
Yes,
that if people noticed it, they would have seen my email on the first slide of my presentation. You can also get it from the web or from the association. Any student has any questions or any help needed about research topics or surgery in general, they're most welcome to email me and I'll do my best to answer them. I just want to offer that to all the students, postgraduates out there. Thank you.
Thank you, sir. Thank you, sir.
Thank you, sir. Thank you.
We'll conclude,
Any
sir.
questions from PGs, sir? PGs, anybody wants to ask?
Most of them have just joined and I think new to the thesis.
I didn't
Dr.
receive
Siddesh?
any questions actually.
Dr. Siddesh,
Hello.
you want to?
Yeah. Shivaram, I think it was a wonderful meeting, very useful. I think any number of times this topic is repeated, even on an annual basis. It is very useful, going to be useful. I think research is something which is needs to be inculcated from the PG days. And of course, dissertation is one of its type of exercise which make them go through this and understand the research methodologies. And I really appreciate all the speakers. They have done a very good job. And obviously, so much of interaction says this is a topic for discussion of the day. As you know, the changes in the scenario, the number of postgraduate students, and also my concern is the changing scenario in the surgery department, general surgery department. When Dr. Lakshman told we need to stick to our department to choose the topics, or Pawan told, I think. But it is very difficult in a present day scenario where so many subspecialties, even the new medical colleges have subspecialties coming up. So the numbers are going to be very difficult to find. And the best way, I have a simple solution, is we need to look at other hospitals which are nearby. I think Lakshman would agree. There is nothing wrong in getting patients, if your selection process is correct, from other hospitals. You can give a acknowledgement to the contribution by the other institutes. So I think even medical colleges teachers should be open to accept this fact that you should be open to accept cases, at least for the study's sake, but without diluting the scope of the study. And I totally agree with Lakshman. We need to be honest. Otherwise, the whole purpose of educating the PGs is lost. So
I totally agree that we need to recruit patients from the private sector as well. I don't even mean teaching or DNB. There are many private hospitals without DNB courses. We're doing a lot of work, lots of numbers. As long as we strictly,
Lakshman, you are right. See, depending on the topic what we choose, there can be an institute which is doing exclusively that type of work. We can look up to them, approach them in a proper way through the head of the institute. Probably they would be very happy to contribute their cases, because they may not be having all the setup to do the research. So I think this is where the answer lies now.
This must be seen as a multi-centric study. And there must be a collaborative study. There must be a coordinator who makes sure that the protocol is adhered to strictly. Once that is done, we can get very useful data.
And lastly, my comment, Shivaram, if you permit me 1 minute. Nanda Kumar mentioned about ASI's role. I really take it up. Should we be taking out and doing an exercise involving experts to bring up the contemporary topics which are relevant, which can be made as a sort of a database which can be circulated to all, where ASI consultants can contribute even to facilitate them to do the studies. So this is a very broad thinking. I think Nanda Kumar mentioned about that. The ASI can really, because all the postgraduates are its associate members. We encourage them. So
IAGS is doing it.
Thank you.
IAGS is doing it.
Published papers as well.
We should start looking at this as a part of our duty to facilitate the postgraduate students.
So you are in the right position as the academic chief.
I am taking the cue. I am taking the cue, Shivaram.
Yes.
Rajan, your comments, sir?
Nothing specific, with very thank you. Nothing special, very concise and clear coverage of the subject. It is always difficult for the first time listener to understand all that we are saying. So I need to say that this kind of talk should be repeated at least once in 6 months or so, and people need to listen to these 2-3 times before they can really understand. As a newcomer listening to these terms, a new PG, it is a little intimidating to understand the whole process. So please.
So they're at least primed now, sir. They're a little bit primed with these
sessions
words.
frequently.
Yes. And it was Dr. Narayan Hepsur, sir, who wanted it at this time before the start of the synopsis.
Also, for the postgraduate students, all these study materials are available in the KSCASI.com. Dr. Lakshman has uploaded, Dr. Ramakrishna has contributed. All the study material is available in our website. Thank you very much. I think our secretary...
There is one thing I would just like to mention, sir. Rajan sir has some 40 steps, the usual CS for thesis. Very concise. I found it very interesting. I think I just spoke to Hepsur sir, and he said he will put it on the ASI website. So the students can approach that. It is a very concise and it is very easy to understand. I hope they refer to that.
He will also share it. Definitely.
Yeah, we'll share it, sir.
Dr. Prabhakar.
Sir.
Prabhakar, welcome to you.
Thank you, sir. It was actually really wonderful. I have just a basic question, maybe stupid. So what is the difference between dissertation and thesis?
Anybody wants to answer, panelists?
So I'll take it up, sir. In fact, that was my first slide. First slide. When you look at dissertation, it is a curricular requirement of a course, like a PG dissertation. Whereas a postdoctoral thesis refers to an axiom or a hypothesis on which you have a research question and do a body of work either to refute or make it happen. So these are interchangeable academic words that we use, but dissertation is curricular, whereas thesis is a research work beyond the scope of thing, which will provide a body of knowledge and science. There are 12 differences, which Google will list it better than me.
Thank you very much.
Thank you, sir.
That was a very good question, Dr. Prabhakar. With this, let us conclude. Yes, Chandru?
Yes, sir. We'll conclude. One more information to all the postgraduate is that this recording will be available in KSCASI YouTube. Whenever they want to see, they can have a repeated look at these to understand better. And we had a wonderful discussion on this topic. And on behalf of KSCASI, I would like to thank all the speakers, Dr. Nanda Kumar, Dr. Pawanindra Lal, Dr. Lakshman sir, and it was well moderated by Dr. Shrishail Metgud sir. And I thank all the executive committee members and all the senior faculty and all the postgraduates for attending this webinar. Thank you, one and all. Thank you very much. Good night.
Thank you. Thank you.
Thank you.
Thank you. Thank you, Dr.
Good
Nanda
night,
Kumar. Thank you
everybody.
so much.
Thank you, sir.
Thank you.
Thank you, Kalaivani.
Good night.
Thank you,
Good
sir.
night.
Good night. Good night, everyone.
Right, sir.
Thank you, sir. Thank you, sir. Thank you, sir.
Thank you, sir.
Good night. Dr. Narayan's
sir.
idea, totally. Thank you. Thank you so much.
Thank you, sir.
Thank you, sir.
Good night, all. Please.
Been made invisible, sir.
Shivaram sir.
Yes?
Chandru, you have made me invisible.
Yake?
I'm not able to put on my video. You have disabled my video.
Illa sir. I have not done it.
You andre Martin, maybe.
Martin ಮಾಡಿದ್ದಾನೆ.
ಈಗ ಬಂತಲ್ಲ.
ಬಂತಾ? ಈಗ ಕಾಣಿಸ್ತಾ ಇದ್ದೀರಾ?
ಗೂಗಲ್ ಶೀಟ್ ಲಿಂಕ್ ಕಳಿಸಿರಿ ನಿಮ್ಗೆ, ದಯವಿಟ್ಟು ಅದೊಂಚೂರು ನೋಡ್ಬಿಡಿ ಸರ್.
Okay.
I have made most of the things and few things are left out. Please fill up the rest of the things. I'll do it tomorrow.
Okay.
Thank you, sir.
Hebsur sir, you seem to be outside the country, sir.
ಇಲ್ಲ ಸರ್, ಬ್ಯಾಕ್ಗ್ರೌಂಡ್ ಅದು ಬಂದೈತೆ ಸರ್. ಐ ಡೋಂಟ್ ನೋ ವೈ.
ಅವ್ರು ಯಾವಾಗ್ಲೂ ಒಂದ್ ಕಾಲ್ ಆಚೆ ಇಟ್ಟಿರ್ತಾರೆ ಸರ್ ಅವರು. ಇಂಡಿಯಾದಲ್ಲಿ ಒಂದ್ ಕಾಲ್ ಆಚೆ ಕಡೆ.
Okay, good night also.
Good night, sir.
Good night, madam. Good night. Good night, everybody.
Madam and Shivaram, thank you.
Kalaivani madam.